title and the subject for today's lecture concerns of how naturalistic studies designs have been involved in developing open dialogue practices, and a bit in the end to say some part of the place of education program for the staff members in the system of open dialogues. And because this is a more or less a kind of lecture of concerning how we should think on the whole of making research on our practice, I have some points also in the beginning to focus in a more general sense of this, the role of naturalistic designs in developing our practices. What is it all about when we speak of naturalistic design? Perhaps the main, most interesting part of it is that now we make an opposite turn concerning how do we see the place of the research in looking for our practices. What is the most popular way of seeing the position of research and studies is that we plan some experiments that are planned in the clinical practice, and it usually means that we plan some program that we want to evaluate going on in the clinical practice. Usually we learn the program, usually we also write a manual for the therapeutic method that is going to be used by defined professionals. And of course, most often when we do efficacy studies or effectiveness studies, we need to have a comparison, and it means that the clients who are thought to use this method are going to randomize into the research, into the study, and into the control group. And in this kind of empiristic trials, the idea is to control all the other aspects of the treatment and to see how the planned treatment is functioning, affecting and causing the outcomes that we want to do. And the control group treatment is also controlled in the way that there is not the study that we are interested of, and also the other aspects are thought to be the same as in the study. Most often this means that the number of sessions are defined in advance. You have, for instance, emotion focus couple therapy for 12 times, more or less, but around the same time. Or the length of the treatment is defined in advance, as well also in the control. So this is a kind of borrowing the idea of laboratory research into our clinical practice. Actually, that's the basis of empiristic research on the whole. In this way, in my mind, we create a kind of clinical laboratory in which the academic research comes and look at what happens there, make a conclusion based on our premises, and give that conclusion to the audience, both for the academic and for the clinical audience. And there is at least one big problem in that kind of study designs, and the big problem is that concerns the external validity of those programs. That can be put into practice in a way that follow the idea to have good internal validity, but thinking of what are the needs in the clinical practice to develop our practice further, it's always a question of how does this study and research stand for the practice that we are taking care of. And for instance, we all who have been in clinical practice know that if we deal with several mental health problems, it's almost never a question of using single methods for this problem. It's always a question of integrating the different methods that we use. And naturalistic design is a try to look at what happens in the real world. Come and look what happens in the real world setting, and without any planning of specific intervention and controlling the other aspects. Of course, we can control the aspects in the purposes of the research, but even though we are more up to good external validity, to the idea that this treatment that we follow have an external validity in the sense that it stands for the clinical practice also that happens in this specific location. In this context, there are doing these effectiveness studies. There are two concepts that usually are used. There are these efficacy studies that are very classical randomized clinical trials, having to control the method and look at the outcome. This is very much a kind of empiristic laboratory kind of trial. And then the concept of effectiveness is used to refer to the studies that are put into practice in the daily clinical practice. Most often in the efficacy studies, the results are better than in the effectiveness studies, because you can control and really have skillful therapists who have learned to use, for instance, in my example, the notion focus couple therapy for depressed clients. But the big problem comes out already since late 90s. There are more and more evidence that 20% of the efficacy disappear when this approach is put into practice in the real world setting. And now, when we focus on good external validity, is to have information of how these methods are working in the real world, and accepting that there is no decline of the efficacy when put into practice, because this research is taking place by the condition that the clinical practice is putting. The plans to designs are always made according to the specific context and of course specific method, specific context. I mean the local geographical context in which happen, the specific context, for instance, treating psychotic patients or psychotic children or whatsoever, and of course specific methods, as in my case a lot of research concerning the open dialogue, even if it's not a single method, but it's an idea to integrate different ideas. And in naturalistic design, it's very important to have different sources of information and different sources of analyzing the data that we gather. And in this sense, the very popular word in science mixed methods is very accurate description of what we need. We need both quantitative data of how the treatment method we make research over is, with kind of outcomes it has, but we absolutely also need qualitative data in the same project to see more precise what happens in the actual treatment process. And actually this is I've been doing this kind of research for 25 years, and this is always the basic elements of it. Always integrate both quantitative and qualitative data in this same process. This is very, because I have a long experience, I have enemies on the both sides of those people who think that in psychotherapy research you are only allowed to do qualitative research. They don't at all like my ways of doing, and of course those who are more up to specific efficacy studies, they say that this is not so accurate because they don't kind of find the explanation what was the causing the outcome that we are looking for. But in my mind, all this means that we move away from explanatory models into a more descriptive models of the system. One way to see it is to what kind of aspects and steps to be taken in this. Again, this I don't at all think that this is the only way to do it, but I very much refer to my own experiences and own examples in which I've been doing. I've been shortly giving quite a few of examples. One important idea that while we do this kind of naturalistic studies, it's possible to do without having the need of having manualized therapy form that before. We can also use this by looking so-called interaction focus therapy methods who do not work based on a manual but are more up to do based on a kind of interaction that stands for the clients and for the therapist. For instance, like client-centered therapies or psychodynamic therapies in different forms. And for me, of course, this idea of dialogical practices is very much a practice which is quite impossible thing to be put in a manualized form, because the interaction at this specific moment is the most important one that is thought to produce the good outcomes for the. But the first step is to make a design that have a follow-up of the outcomes. Of course, the outcomes time can be dependent on what is realistic for us, but usually 1 year or 1.5 year or 2 year already gives a very good idea with what happens. For instance, I've been doing a lot of research in psychosis, the longest period being 5 years follow-up. But I can see that at 2 years point we already could see in mainstream, in the main ideas of the outcome. Of course, it's very important to have longer term follow-up, but easily in the 2 year point we already can see how this method that we are researching are working with this basic group that we have defined. And when we know the outcomes, we can make a selection of specific cases based on the outcome. We can make, for instance, quite useful for me is to do this poor and good outcome comparison in very different form. Choose of those results that we know are patients who, for instance, in the beginning were both diagnosed with schizophrenia or what specific, they are comparable, and then make a comparison between what were the good and what were the poor outcome. And actually, in that sense, by doing, we start to have a very precise information of what happens in those that lead to good and those that lead not so good outcome in the processes. Actually, I could say that this is even more precise than we most often have when we look at the manuals who try to in advance say what happens. But now we know we have video recordings of the session, or we can make in-depth use of the clients in different forms, and this can be very accurate information of what really happened. But we cannot, of course, do any conclusion if we do not integrate results of cases to the statistical data that we have. I thought to show an example of this is not so much open dialogue practices. I have been a part of it. This is a project that I'm involved and in charge at the moment, dialogical and narrative processes in couple therapy for depression. And I've been, it's a presentation I had a couple of months ago with Dr. Eija-Liisa Rautiainen, who was also a researcher of this. I thought to show this a kind of example what aspects could be taken into account when we make a design for this study. This was thought to have, as the title said, look for couple therapy for depression, and especially the dialogical narrative processes for the depression. And what we did, there were 3 sites in Finland, 3 psychiatric units, psychiatric districts who announced to be willing to be part of the group, and each of these the depressed clients were randomized into the treatment, couple therapy or control group. And this is naturalistic to studies design, which in this means that what happens was to follow what happens in the real world by trained family therapists. The specific quality that we do couple therapy and family therapy in Finland, it's most often taking place in a co-therapist form. There are 2 therapists, and now we wanted to have those therapists to have a trained according to the Finnish law as family therapist or couple therapist. But we did not keep any training especially for the purposes of this research, but we wanted to see what happens in the daily clinical practice after they have the training as being psychotherapist or family therapist. And there was no definition of the number of meetings, there was no idea how long the treatment will go on, but perhaps the only criteria was that if you should have at least 5 meetings with an idea that in 5 meetings you have a kind of process of couple therapy. If it was less, they were not included into the process. And then afterwards, in many ways, the therapy processes were assessed in relation to the treatment outcomes. The main aim, there are 2 aims became, and the main aim is here to develop couple therapy for depression. And actually already this is a very different compared to the empiristic designs, because in empiristic design it's almost entirely the focus is to have an information of the outcome, the efficacy of some methods, but here it was done, that was of course to find out what is the effectiveness of couple therapy for depressed clients, but compared to the individual based treatment as usual, but also to have directly feedback and information for the therapist to proceed in their skills with working with depressed clients. And concerning the qualitative data, well, it's quite profoundly resistant. We had all the sessions video recorded, or some cases audio recorded if the couple didn't want that. In every session, the clients fill the outcome rating scale before they come into the session. It's a short visual analog scale with 4 lines to fill. How am I today and the week before these meetings? And after every session, the clients fill a kind of session rating scale. Again, it's an evaluation. How was the session for me? Did I become heard? Did we discuss of right issues? Did the therapist working style fit with me? And how is the sessions, example? Very simple ratings. And for our purposes, we also develop a rating for the therapist to do the same ratings. And then after it was over, after 3 years, the team and the therapist and the couple were invited into co-research interviews, in which first the team members, therapists were interviewed of their experience with working this couple, and after that the couple was interviewed to comment what therapists can also give their experience. So in this way it was a kind of comprehensive idea. For the purposes of doing the analysis of the research, we have developed specific dialogical methods in investigations for happenings of change, and this is a part of a bigger project to try to have a means to look what really happens in this kind of multi-actor dialogues. And now multi-actor dialogues, I mean that there is not only one therapist or one doctor and one client, but that there can be more professionals and more clients at the same time. The effectiveness of the couple therapies were measured in a quite classical information. There was a kind of interviewer assessed depression by Hamilton Depression Rating Scale. There was a self-report inventory EDI and symptoms checklist 90. And there was a dyadic adjustment scale for the couples to be used. This BDI was asked both of the one who was depressed and of the spouse, from the spouse, as well as the DAS also was used for those. General function level, there was a concern of if there's a violence related and how much use of alcohol is related with this problem. And all the measurements were done at the outset before the treatment started, after 6, 12, 18 and 24 months from the. Here is a bit problem because there is no definition how long the treatment should be, and it's very difficult to define the follow-up period in this kind of issue. So actually for that reason we gave up to the idea to have precise follow-up, but we have done some follow-up in statistical. They're chosen by patients there who would have been in treatment for 6 months to 1 year and then followed up. They defined what happened after that as a kind of follow-up. Well, we perhaps don't need to go. There were perhaps to say some words of some specific aspects came here, and the resection, those who did not want to be part of the study, that was rate was quite big. So all in all, about half of those we asked denied to participate in it. And the denial was greatest in the units who were not so much used to work in couple therapy. The more the unit were used to work with families and couple therapy, the less rejections came in according to the willingness to participate in the study. I think that this is one of the major challenges in this kind of designs. That was also I was a bit disappointed that so many didn't come. But actually no significant differences between those who did not come to the study and those who came. There are some interesting outcomes concerning, I leave some information away here because even if it would be important to see the background information and so on, but because of the time. But only to highlight some aspect of what kind of information we can have in this. Now we have, for instance, the information that the groups, the research group and the control group, they had a difference in the number of therapy sessions and number of other treatment events. And that was a big surprise to us. As we see here, concerning the research couple therapy group, of course they had a much more couple family session. Family session means here couple therapy. But because control group was also allowed to have meetings with the family, with the spouse, but they could not be a kind of, have to have any therapeutic content, but to be informed of the depression and so on. So there were approximately this number of two meetings in the number of other psychotherapy sessions, of course, it's a much bigger in the control group because there are many patients in an intensive individual psychotherapy, but also some of the couple therapy group clients were in individual psychotherapy, or actually there is also some cases who are in intensive group psychotherapy treatment. But then what is most interesting is to see number of other treatment areas, which is significantly smaller in the research group. And all in all, there is a big difference how many treatment sessions these clients use. And in the way that those who were in the couple therapy had a much less need to treatment to be used compared to those who were in the individual treatment. This means mostly consultation with psychiatrists. Yeah, please.
Medication an aspect of this?
Yeah, they could have medication if that was seen suitable. So in a couple therapy group, the use of medication was a bit less than in the control group. About 2/3 of the client, little less, 60 to 65% used antidepressant medication. And it was in the end it was around 35 to 40% that was antidepressant medication. So all the aspects of treatment were available if that was assessed necessary. Yeah.
The number of other treatments then is not medication visits.
It can be medication.
Oh, it could be medication.
Yeah, it could be. Yeah. It could be medication visits. For us, this says that at least we have discussed about it that also in the reports that we have given, that perhaps what is the advantage to having the spouse in the treatment? It seems to make a structure into the treatment in the way that there is less need, for instance, this all of a sudden consultation to the doctor and changes, needing change in the medication and so on. But all question of medication and so on, they are. And then we also can see that the outcomes are different, and this is a kind of illustration by the PDI, which was visible also on other cases. Those who were in couple therapy, they recovered more rapidly from depression, and the first difference came out in the first 6 months, and this difference stands for the entire end of the entire period of time, and those who were in the individual treatment as usual, they started to have again kind of new depressive symptoms after the treatment. And some notions of the outcome was that in couple therapy group, significantly less therapy efforts and significantly better outcome in depression and general mental health. General mental health here means the symptoms checklist 90 reports that they were given. And 79 and 71% had significantly improved by the science. This is very surprising information, because in single method efficacy studies, most often the recovery rate is somewhere 50, between 50 to 60, and even this is in psychotherapy research nowadays we use a kind of clinically significant change, no longer a statistical significant change. And this significantly improved include both recovered and those who significantly have improved. So this rate is quite high, even higher than mostly in the efficacy studies. And as I said in the beginning, that in efficacy studies we usually lose 20% of the efficacy when the method is put into practice in the daily clinical work. But here is the opposite. This should be valid of the everyday clinical practice. And now, of course, the idea here is that we did not control, for instance, the medication or other forms of possible treatment that was needed. It seems to be the case that this really gives more valid information for the daily clinical practice than a single method study. Some ideas. I thought this was enough as an example of this study, but if you have some comments or interest in this. There is, of course, then there is a lot of research done. There's a very interesting reports concerning the co-research interviews, which are very sensitive ways of having interviews in which the therapists are interviewed of their work in the presence of the clients. And those questions, therapists usually say that I'm not used to think of those kind of issues. There is a lot of research students doing on concerning using the dialogical method, how are the dialogues going on, what happens here, and so on and so on. So we are building up a kind of body of data that are reported in different small products, but of course we already have a first sketch as a kind of conclusion, as a recommendation, what would be a good elements to have the couple therapy put into practice in public sector settings in the Finnish context. So this focusing on moderate or major depression has been my interest lately, but a bit different. Not only no longer focusing on what happens to it. One thing I forgot to say. Then there is I said that we have 3 different sites in Finland, and these sites differs in the sense that what is the role of family or couple therapy in the clinical context. One of the sites is the site of open dialogue in Tornio. Another site is in the central of Finland, which is more a kind of, how would I put it, method-oriented, but they are very open to contribute with all methods. They have a long tradition on individual psychotherapy, but they have a lot of couple therapists trained there, and so on and so on. And the third unit is very individually, and I would say also in a very bureaucratic way, organizing the treatment. For instance, in that unit you cannot, because this is a part of special healthcare, you do not have access to come into the therapy in the special healthcare if you do not have 2 kind of tries of different, two treatments before that. Usually it means that you should have at least 2 medication periods before you have an access. So it's a very bureaucratic and not at all so good way to come into the treatment. And there were differences in the outcomes, both concerning the treatment needed, and that was less in Tornio in this open dialogue orientated, and the outcomes were better in Tornio. So people could recover from their depression after 5 to 7 sessions in couple therapy. And that was, for me, was a surprise, because I thought, I used to think that in psychosis it's very important to focus in a crisis to have the idea. And I thought that depression is a bit different. Depression needs a longer term therapeutic process. But actually what came out of, as a conclusion, the more you focus in a crisis situation to see the depressed client, the better probability for good outcome you seem to have. So the crisis idea, crisis intervention idea, helping people in depression is to be as important as psychosis. But that was in a bit positive surprise to me to learn in this process. Okay, then I thought to have an example of how this idea of naturalistic designs are put into practice while developing the open dialogue system in Western, mostly in Western Lapland, some places otherwhere also, but most of the studies are put into practice here. What is open dialogue in Western Lapland? So this I thought not so much focus here, but perhaps I need to say some words. We started to, I was working as a clinical psychologist in this small psychiatric hospital in Tornio in Finland, which is located in Lapland. And we were a team with 2 doctors, 2 and 3 psychologists, some nurses, who all got an interest that we want to have a family-based psychiatric system. And first we did a lot of individual psychotherapy and family therapy with these clients, and we felt very uneasy of this being so separated from each other. And then the big opening for the new way of organizing came when we heard 1984 of the idea that was developed in another part in Finland by Professor Yrjö Alanen and his team, to have open meetings in which always the family is invited, in which always the patient is present from the very beginning. And then we came up to have staff meetings for the planning of the treatment, and only have meetings when the client, when the patient was there, and follow the idea that whenever something is decided concerning the family should be there in the present. So these open meetings became a kind of forums in which the families also came a kind of allied to us. Even if in the beginning we were very confused with this what happened, because we had an idea that we have to plan the treatment, we have our intervention, most of the family therapeutic intervention to have change in the family, but that many times led into a dead end, because families have when they were there from the very beginning, they took a very active role in the situation. They were not at all, they had not at all come to listen to our ideas, how should it be, but they became active participants and had a lot to say how would they want this treatment going on. And many impasse situations that came out of this, that we thought that we are the healers and you are the objects to be cured of their problems, and they thought that they are active participants. And in the end, we were many times in the situation in which we realized that we have to change first, because the change can start in our working alliance and consequently in families' behavior. And after this kind of many confusing experiences, we came into 2 conclusions. The first conclusion is that the education that we have does not give adequate prerequisites for working in this new kind of setting, in this open collaborative setting. And secondly, that all the information in textbooks, and treatment of psychiatry does not at all support the idea, and we were in a way forced to start to make analyses to understand ourselves more. What is this all about, and what are the basic elements, and of course to see if this really is productive way of working, because there were long periods of time in which we did not know if this is a good organ. And for that reason, in some years, 87, 88, we came into a conclusion that all staff have access to 3 years training, and that is going on all the time. In the end of my speech, I will say some words of those training ideas. And the second idea was that to start a kind of systematic research and analysis of both of the processes and of the outcomes in this situation. And of course, now from the very beginning, of course, it is kind of self-evident that here the research was thought to follow what happens in the practice and to give information for the practice, and not the practice was not planned because of research interest. And that also has caused us a long way to search for methods that fit to be applied adopted in the daily clinical practice. Some studies, and I will say some studies, if you are interested, we can also go into the details of the methods, but I have mostly taken those out here to see what kind of information comes available, especially thinking for the needs of the therapist, our therapist as selves in this system. The first last study that was conducted happened year 1988 to 1991, and in that study we had an interest to make a research of what happens in the admission. I have to say one more point of this. When we came 84 into the idea of having open meetings with the families, we realized that we have a big problem in the system our work is organized. Because, for instance, when I was working as a clinical psychologist in the hospital ward, one patient came into the ward and easily took 1 week or even 2 weeks before we have enough time in our calendars to have meetings for the family. We had to totally reorganize them. And then we realized that when we have the first meeting after one has come admitted into the hospital, it is too late. We need to have meet with the family already before the decision is made. And for that reason, 87 we opened up a practice to have a kind of polyclinic team, and which responsibility it came that always when there was a referral of some patient to come into the hospital, this team organized a meeting together with the staff of the ward and the family to evaluate the situation and make the decisions of the treatment. So after that, no one could have access to hospital without having the meeting with this kind of admission meeting. And that was the basis for the first study to see what happens, what are the elements that happens in the admission meeting. At that time, we called that a boundary. Okay, so what happens on the boundary between the hospital and the family in a severe crisis? They were not, they could be whatever patients. At that time we had a much more focus on hospital treatment, so they were not only psychotic, they could be have severe depressive problems, they could be a lot of personality disorders and so on. What we found out in this research, that was both a follow-up and it was 1 year follow-up added with 3 more years, and look at the process. First, we found out that there are differences concerning the admission situation if it was a question of the first hospitalization or recurring hospitalization or hospitalization with a long-term patients. In first hospitalization, the families had a big anxiety, and they were very willing to approve the idea that our son or daughter or family member is not hospitalized, but he or she returns home, and the team takes charge of the treatment. Family was there in every case. They were very motivated to be there. Whereas in the reoccurring crisis, means that people who still are in their works and so on, but they are in reoccurring crises. What happened was that families' meanings were the most important ones in finding the solution if one is hospitalized or not. If the family had an experience that previously our family members was hospitalized, it was much more difficult to approve idea to go back home and have the treatment home-based as it was in the first case. And in case of the long-term patients, they were already all living on a psychiatric pension and not working and so on. A kind of being a psychiatric patient has become the basic rule of their basic identity of their life. And again, we very carefully followed the path that was open, and it was not possible to make rapid changes in that. So we learned that it's very difficult to realize what kind of history these clients have to psychiatric system when we make decisions, a shared decision. Then we realized that there was a comparison. How is it different compared the single admission interview that a psychiatrist does, and the main difference was in the idea that when the team is there, so the team only have an access to broader respect concerning the social context of the clients, whereas the interview of doctor is very much focused on the symptoms and on the individual, and it's more difficult to have the social context involved. In this research, we generate the first ideas of the importance of dialogues in many respects, and the first conclusion actually is the one that we learn in a very, how would I put it, very clear way. Don't force the family to accept the whole treatment instead of hospitalization. You have to go in line of the experiences that the family have. If we try to force them to accept, it could lead to a very unfortunate situation. Then, I wonder if you have some comments or questions, perhaps something that did not became clear enough in this time. This is concerns adult psychiatric, adults who come into the psychiatric. Yeah.
Well, I was just going to throw out that we have adopted in child work here an approach of what's called wraparound services.
Yeah.
And that's because of a state mandate, because of a child getting stuck in a hospital that couldn't get out for her whole childhood. And wraparound services sounds fairly similar, which is the child's not in a hospital, but the child's home. But everyone comes together.
Yeah.
And a treatment plan really consists of everyone's input, and not just the professionals. And I do think there's merit, and I think that there has been successes in what have been seen as fairly impossible situations.
Yeah. Yeah, I know something of the wraparound system, and in my mind it's very nearly connected, related with the ideas that we put into practice in the all the time. Absolutely. Yeah. One thing that I forgot to say, that in this first research, when it was in 40% of the cases who had a referral to hospital, the decision to hospitalize was dissolved before they came in. So actually, there was by working this way actively with the family before the decision made, almost half of the hospitalization would be dissolved already before it has started. And when it started, it would become shorter, but in this study we did not have that kind of influence. Then more probably in the studies concerning psychosis, these studies are put into practice in 3 episodes. And this, I should have written down it. This, in our studies, consists of so-called non-affective psychosis that are included in all of this. And these studies concerns of first episode non-affective psychotic patients who made a contact neurosis. The first inclusion period was from 92 till the end of 93. It was a part of Finnish national study named Integrated Treatment of Acute Psychosis. The aim of this study is to see the function of the new system, but one specific question is to find out what is the role of antipsychotic medication in the treatment of psychotic patients. And therefore there was a kind of multi-center situation in which 3 of the 6 centers did not start the antipsychotic medication in the beginning of the treatment. We were one of those sites, and it was decided medication is only started if this psychosocial intervention is not helpful enough in 3 or 4 weeks or even after. Because we got such an promising and interesting results, we decided that we will go on with this with our own project, and immediately actually followed up with the period called Open Dialogue in Acute Psychosis project. That was put to the inclusion period from 1st of January 94 until the last day of March 97. So actually, putting all this together, we had a 5 years inclusion period in the first round of research. And then the third period of research called Open Dialogue in Acute Psychosis second is a bit specific because what happened, I will shortly tell of the results. What happened was that after we started to publish the results of the studies, so we have been criticized that these results are too good. They cannot be true. And actually someone has accused that we have selected the easiest patients and excluded the most severe. And for that reason, we took a new project, 2003 to 2005, to have a new sample of first episode psychotic patients to look for if the outcomes that are still there that we have had until 10 years before in the previous period of research. Again, this is a kind of advantage to make in naturalistic designs because now we have the same system going on. Actually, the system has been going on in Lapland for 25 years, and we can follow. We do not need to have a new specific program project to make an evaluation of it, but we can come and start to look what happens in the real world system in this setting. I come soon after into the results of this. A big project that became very important for us was a project with Professor Professor Jukka Aaltonen and myself, 1994 to 1996, and we made an analysis of the change of the system from hospital to mobile intervention psychiatric system, from hospital-oriented, inpatient-oriented treatment into the treatment that mainly happened in home settings organized by the mobile crisis intervention team. And this study was done by analyzing 3,000 patient records of first episode psychotic patients, and in the records we followed up those patients for 2 years' time to see how their treatment has gone and made a comparison. What is the difference between the inpatient focus and the crisis intervention focus treatment system? We could have also a kind of neuroregistration of the change of incidence in schizophrenia. And we came out as a part of the qualitative analysis, the main principles of open dialogue came out of this study. It was done a kind of content analysis, but with the application of grounded theory ideas. And these are the main principles that came out. So when we speak, perhaps already many have become aware, known of these basic principles of open dialogue. These are outcomes of specific research. They are not, in a way, principles that we plan in advance and then try to follow, but actually opposite. We have a system of treatment, and then we go and try to look what happens there, and these are a kind of outcomes that describe the optimal treatment process. The optimal treatment should guarantee immediate help, to have the first meeting within 24 hours after the contact has been made in the psychiatric system. Secondly, the optimal treatment should always, as a first thing, include the social network of the client into joint meetings and include the network, the entire treatment period, that we call social network perspective. Most often, not, of course, it means the family, but in some cases it also means in if it's young people or children, the schoolmates or teachers and so on, or in adult fellow employees and so on and so on. And also the other professionals who are involved in the system, who have a contact with this family either previously or in this specific phase. The third conclusion was to be flexible in the methods that we use, be flexible to adapt those methods that fits better to the specific needs of every patient and every family. And mobility was a big concept for us at that point of time. Go out from the institution, go homes, whatever is the best place to meet with the clients. The fourth conclusion was that the optimal treatment seems to guarantee the responsibility by the team taken from the very first contact on. That the team or the one who is contacted have made a decision to have the meeting. Actually, what we came out of this was that we started to learn the idea that all those workers, whatever their place, unit of working is in this geographic area, they are responsible to have the first meeting in case they are contacted by some client. It's no longer allowed to say to some clients, for instance, mother calling because of her concern of her daughter. When I used to work there as a psychologist in the ward, I did not have a responsibility for the community mental health. But in any case, if a mother would call me, and it happens sometimes, and describe the situation, I was not allowed to say that this belongs not to me, you have to take contact there and there. And the mother would describe that her son has been drinking quite a lot and he started to behave in an obscure way and so on. And I got an idea that perhaps the son's problem has something to do with alcohol use also. So I proposed to mother, could you, when I listen to you, I started to think that perhaps Pekka's problem, the son's problem, has something to do with the alcohol drinking also, alcohol abuse or alcohol misuse also. Could you approve the idea that when we come to you tomorrow morning, I invite someone from the A clinic, from the specific clinic to come there. In that way we integrate the different services. And then in the meeting we can decide who are the best one to take responsibility in this case. And this is already one part of this guaranteeing psychological continuity, that we really have access across the boundaries in different systems, access across the boundary between inpatient and community mental health, but also access across the boundary from social care into a child psychiatry and from child psychiatry into adult psychiatry if needed, if in some family there is both sides, the kid and the mother who are in trouble, and drug use clinic and so on. Psychological continuity also refers to how do we integrate different vendors as a part of the treatment process. And then as a kind of seeing what happens, what is the content of what happens in the system, is to focus on tolerating the uncertainty, so that there was really a kind of forum generated that tolerate uncertainty, instead of thinking that the team all the time react to what happened. If there is a kind of arisal of anxiety, it does not mean that you immediately need to put more medication or immediately you should move home to the hospital, but the teams together with the family can now tolerate the situation, the uncertain situation, and be together and try to look next time how it is. And the last point was to focus on dialogue. What seemed to be optimal also in this research was that the more the process was occupied of generating a general understanding what this is all about, instead of focusing only of the symptoms of the clients or only of the family interaction, the better the outcomes. So this was a very large, mainly qualitative inquiry that we did, but we also made a statistical registration of the incidents. There are a very new research report actually published only some 3 weeks ago that I will see so shortly, also including the statistical information of the change of incidents. Then there are some specific studies focusing on dialogues. So we are very occupied of the dialogues. My colleague, clinical psychologist Dr. Kauko Haarakangas, made a last study of which is named Voices of the Treatment Meeting. He was interested in what are the voices that appearing in the meetings with the clients, and actually having a very interesting point of view, because what Kauko referred was that these voices, and voice, I don't mean any hallucinatory voices, but voices as how the speaking persons comes out of them. The voices that comes out of these persons who are sitting in the same room in a horizontal level, but then it was Kauko's notion that there are always also the voices that comes with everyone as based on their life experiences. The voices of being a father, the voice of being a mother, the voice of being in the work by these different duties and so on and so on. How these voices were a part of the dialogues in this. And there was a comparison with the new, this happened in the training situation, and he made a comparison what are the non-experienced therapists doing compared to those who already have an experience, and actually found a difference in that respect. Myself have been doing quite a long work with this, looking at the quality of dialogue. The first report was a comparison between poor and good outcome in psychotic crisis, and a kind of second generation of the same method is now published in the name Dialogical Methods in Investigation of Happenings of Change, that focus on what actually happens in how the responsive process is taking place. When we speak of dialogue, it's a focus that shifts, not so longer being so interested on the interviews, on the questions, but what is much more interesting and important is the responses. What are the responses and how the responses contribute to the ongoing process of having more understanding of the situation. This is, I hope you can see it, this is only a conclusion of the open dialogues with good and poor outcomes for psychotic crisis. General frame, a summary, which already gives some interesting information of what are the differences with the dialogues that led to good outcome compared to dialogue that led to poor outcome, not so good. We could see that there's a concept that we do call as dominant, or interactional dominance. Means that how much the clients can take initiative of the way how the dialogue is going on. And there seems to be a difference. In good outcome cases, out of all of the episodes that were looked more than half the clients could make those initiatives. But in poor outcome cases, it was much more seldom the case. So it may be that one element of a good optimal dialogical process is that there is some flexibility in the way who can make the initiative. Of course, the therapist, but also the client has access to affect how do we discuss of these issues. No difference compared to semantic dominance. Semantic dominance means what do we speak about? What is the content of our system? It did not seem to matter in the difference. But then there was a very big difference in how much the discussion, the dialogue happened in a symbolic language. There is now division into two ways of being language. Symbolic language, symbolic meaning making is the one that we are as adult and especially as therapists are used. When we speak, we refer to words, and one word can have many meanings, and it's always related to the specific context in which this word is used. This is a symbolic meaning. But in severe crisis, there seems to be, for instance, families who don't have access to this kind of symbolic language. But maybe because of the crisis, maybe because they are not used at all. They use, as Russian psychologist Lev Vygotsky called, a kind of indicatory language. One word refers only one thing. And it's very challenging task for a therapist to be living in that kind of situation. Language is very concrete, and we need to learn how to work with this concrete. In the poor outcome cases, there seemed to be not at all access out of this indicatory language, but only in maximum 1/5 of the episode could include some symbolic elements of the language. So actually it's a very challenging task for the therapist to learn how to help the clients to develop symbolic language. It does not help that we as therapists only speak in symbolic meanings, because actually that doesn't mean anything for the families. They only can follow the idea that this, when we speak of chair, we speak of this chair that is visible for us. And the same type of, not so clear, but a kind of tendency was that the more there were access to kind of core dialogical utterances, the better the outcome would become. So actually telling that aiming at a kind of dialogical interaction, dialogical exchange of idea is a very good for good outcome. And if we manage to have that kind of speech instead of monological utterances, that is good for the clients to have mastery in their life. A bit more advanced form is that, as I already said, that's already published in an electronic form in Journal of Marital and Family Therapy, making sense of multi-actor dialogues in family therapy and network meetings. And it is based on the previous version, but now we have much more focus on the responsive processes. I will only short say about this. Yeah, that's the only that I have here. And now this happens by in 3 steps or 4 steps. First, having one session as a film. This can be used both in clinical purposes. Actually, I use this idea quite a lot in, for instance, in 2 days workshops or consultation with some units when we meet together with clients. But in research purposes, we usually need to make a transcription of one session, and then we divide the session into topical episodes. Topical episode means that what is spoken here, what is spoken there, what is spoken in the third phase. For some reason, I don't know, perhaps only by chance, when I was mostly occupied with the families in psychotic crisis, there seemed to be in one session about 30 to 35 topical episodes. Now lately I've been occupied in this couple therapy for depression stories, And for some reason there seems to be some between 30 to 35 episodes there. So it's quite funny to, it's not an important, but only a be curious that how come is it that there seems to be a number of themes that we discuss in one session, and that's it. After that, in each of, we have the episode, in each of the episode we look for the series of responses that happens there. How are the, with the question, who have the dominance, that was also already spoke here, interaction and semantic. But also, what is responded to? Is it responded to what was said here, or is it responded to the emotions that emerge while someone is speaking of some, is being at the moment, present at the moment, or being present in the story that the people tell. And the very interesting question is what is not responded to? Because in every utterances people say many things. Many times, for instance, one can say one husband said six things in one utterance, and therapist all of a sudden shows one of those 6 points he responded. And it was very interesting. So what happens after that response? Is that response contributing and generating a new idea, or is that response something that stops going on in that case? Even if for us as a researcher it was very surprising comment in this respect the therapist did, but it was very helpful for the couples to follow. And the third point is to explore the processes of narration and the language area, and actually the point of looking for if this is symbolic or indicative language and how does it mean. And after that we can choose some specific interesting points to a microanalysis to microanalysis to see more precise what happens there. Okay, then I thought to say some of the outcomes in these psychosis studies that we have had. The first one was this first reports including the 2 first periods, the integrated being a part of the national study and of the local open dialogue in acute psychosis. And this is a report published 2006 in Psychotherapy Research Journal. And aim, looking perhaps interesting here, is to look at the aims. With specific aim in this project is to increase the treatment outside hospital in home settings. That is the project on the whole in open dialogue. And the second aim was because of the national study to increase knowledge of the place of medication, and in that sense the antipsychotic medication was not started, but it was postponed and only used if needed. And later 90 patients was met at the outset. Some of them actually were excluded already at the outset, but with 80 we had a 2-year follow-up and 76 5-year follow-up. Actually the attrition rate was very low, surprisingly low interviews. Perhaps it follows with the idea that we go home, so people don't need to come into the clinics to interviews. Important aspect for us is always do the follow-up interview in a shared experience. Always the team and the family is invited in the follow-up interviews. And this is a big difference again compared to empiristic trials, because it's most often thought that there is an outsider researcher coming and making an interview with the rating scale of the clients. But we want to have those be a kind of situation in which the therapists have a feedback of their work immediately. They don't need to wait 5 years, the reports of the research are published, but they have a feedback of how was this immediately, and they can learn and use that knowledge in developing their practices. The mean age of the clients were 22 and 6 years in the first row, and 60% had a diagnosis schizophrenia. At that time, schizophrenia, form of psychosis and schizophrenia were divided. No longer there is no division of that. The first question was, do we manage to decrease the need for hospitalization? And while doing the comparison between these two periods of inclusion period 92 to 93 till 94 to 97, and both in first 2 years and the years afterwards, you can see a significant difference in the number of hospitalizations. Both in the first 2 years, those who came into the treatment in the first phase had a lot more hospitalization days compared to those who came later on. And what does this mean? Even if they were very same type of patients, in the problematic in the background there were no differences according to patients, but the staff members can learn to tolerate the uncertainty in a way that there is more access to take care of at home, outside the hospital, serious crisis situations. Especially longer term hospitalization had stopped entirely. In this period there were no one more than 10, highest number was 10 days of hospitalization. The second question of what is the place of neuroleptics in the treatment, how does it affect? It was seen that those who were on those who did not use neuroleptic medication on the whole, at 5-year follow-up, they had a lot better outcome concerning psychotic symptoms than those who had used or were on continuous medication. Here it's more or less self-evident because we want to choose the most serious patients who really are thought to be in need of medication, and those who don't need medication, they are not medicated. But it also said that avoiding medication did not increase to the probability to poor outcome. It's the same concerning the relapses. Those who were on medication had more relapses compared to those who were not on medication. And this is the outcome that we have been criticized mostly, because people say that this is unrealistic. At 2 years old, let's see this at 5 years period of time, 90% of the patients were living on the disability allowance or passive. And this is very different. Okay, we can take this to see how is it related. To make it more understandable, I have taken here an example of another 5-year follow-up.